A very good evening to one and all present here. It is with great pleasure that we, the Bilroth family, welcome you all to the CME Ortho Insights, Navigating the Future of Musculoskeletal Medicine. We are honored to have Dr. Prem Kumar sir, a senior orthopedic surgeon, who will be chairing today's session. Thank you so much, sir. It's a pleasure to have you here. Sir needs no introduction amidst us. He has been the first orthopedic surgeon of Bilroth Hospital from its inception in 1990. Sir has completed his MBBS from Madras Medical College in 1979. He obtained his diploma in orthopedics from Keelpok Medical College 1983 and graduate MS Orthopedics from Keelpok Medical College in 1987, after which it has been a tale of honor from his patients. We request Dr. Durayarajan sir to welcome the chairperson with a bouquet of flowers. Requesting Dr. Prem Kumar sir to proceed with today's session as he introduces the speakers for today.
Respected Dr. Raj, Dr. Balaji Sai Baba, Dr. Barni Ratnavel, Dr. T.V. Raja, and my colleagues who have assembled here, who have gathered here to attend the CME. It gives me immense pleasure to chair this session on current insights and future perspective of musculoskeletal problems. We have 4 eminent speakers who will be discussing the various orthopedic problems. I am thankful to the management of Bilroth Hospital for giving me this opportunity to chair the CME. Now a few words about Bilroth Hospital. I have the privilege of being associated with Bilroth Hospital from its inception in 1990. It was started as a small 20-bedded hospital with 4 consultants, and over the period it grew leaps and bounds to become such a huge multi-speciality hospital. I also had the good fortune of working with its founder, Dr. Jagannathan, who was also my college mate. Dr. Jagannathan used to be very friendly with his colleagues, and he used to tell us, it is your hospital, and he made us feel that it is our hospital. He used to spend a lot of time in the hospital, and in the early stages, he used to visit all the inpatients and have a few words with them. It was due to his involvement and hard work that the hospital has reached this stage. I am happy that his son and daughter-in-law are following his footsteps to bring this institution to a greater glory. Now, as in the other branches of medicine, the field of orthopedics also has grown many-fold with the advances in imaging technology and surgical instrumentation. Our senior consultants, Dr. Durayaraj and Dr. Balaji Sai Baba, are doing extremely good work to keep the hospital at par with any other hospital in the city. The knee replacement cases done by Dr. Durayaraj are perfect with good range of movement and alignment. All the polytrauma cases are managed extremely well by Dr. Balaji Sai Baba. I once again thank the organizers before starting the scientific session. I shall now introduce the speakers. Our first speaker for today is Dr. Balaji Sai Baba, consultant orthopedic surgeon with expertise in trauma care, arthroplasty, arthroscopy, pediatric orthopedics, musculoskeletal oncology, and deformity correction. Dr. Balaji has completed his MBBS from JIPMER in 2008, graduated his MS Orthopedics from PG Chandigarh in 2012, and completed DNB Orthopedics in 2013. He became a member of National Academy of Medical Sciences, MNAMS, in 2013. Completed the SICOT diploma in 2015. He has done fellowships in arthroplasty and trauma in various renowned centers across the globe. Today, Dr. Balaji will be discussing on polytrauma, challenges and management. Yes, Doctor.
இது சாரோட ப்ரெசன்டேஷன் என்னோடது கிடையாது. இது சாரோட. Everyone, I thank the Bildroth management for giving this wonderful opportunity to present before you, and I thank all of you for attending this CME on a leisurely Sunday evening. So let's start with the topic. So today I'm going to present about challenges and management of polytrauma in our hospital. So polytrauma by definition is significant injury to more than 2 anatomical regions. For the sake of definition, the human body is divided into 6 regions as shown. So apart from this anatomical classification, a few more addition of other metabolic responses, like at least one of the following 5 metabolic physiological responses should be there to qualify as polytrauma. That is hypotension, unconsciousness, acidosis, coagulopathy, and age more than 70. So this is the current definition followed right from the year 2014. It's called the Berlin definition of polytrauma. So it involves multiple injuries involving multiple systems. So without a dedicated team for the polytrauma, it will be like multiple presentations involving multiple systems. So without a team, it will be like 6 blinded scientists describing an elephant. So what is the importance of polytrauma? Why do we need to care about it? So it can cause significant disability since it is involving multiple systems, and sometimes it can be even life-threatening. So we need a dedicated team for efficient management of polytrauma. So this team should comprise of a trauma surgeon, that is, or a general surgeon, thoracic surgeon, vascular surgeon, neurosurgeon, plastic surgeon, orthopedic surgeon, and an efficient radiologist, emergency physician, and anesthetist or intensivist. So the elements of successful management of polytrauma can be divided into the need for a multidisciplinary team. So timely diagnosis with all the available investigations and appropriate intervention, either limb salvage or life salvage followed by skeletal stabilization. So let us see some of the cases of polytrauma managed in our hospital successfully. So case number 1, it's a 55-year-old lady, fall from a 10 feet height, presented 16 days after the injury to us. She presented with thin extradural hemorrhage, hemothorax due to multiple rib fractures, perinephric hematoma with a hemoperitoneum, and she had multiple fractures. So this was the only open wound which the patient had. On presentation, she had a sutured wound with literally pus pouring out of it. It was infected, foul smelling. Once the sutures were removed, that was the condition of the wound. And so this was the wound after debridement, and it healed very well with skin grafting. So these are the list of fractures which the patient had. So most of them could be managed conservatively except for the last 2. The shoulder fracture dislocation and the femoral head fracture required operative intervention. So for the rib fractures, since the patient had a hemothorax, patient needed a tube thoracostomy with an underwater seal drainage. These are the images of the spine fracture, transverse process fracture, and the elbow fractures. So on the first go, it's very easy to miss a fracture in this image. Since the patient had difficulty and painful movements on the right side, so we took a closer look. Still, it is very easy to miss a fracture on this image. So we took a CT scan which showed the femoral head fracture. The fragment had completely rotated and was lying inside the femoral head joint. And we can see adjacent pubic rami fracture as well. So this is a close-up image showing the same. The femoral head had fractured and the fragment had completely rotated. So this fracture is called a Pipkin's fracture. It needed an internal fixation with headless compression screws. So the image shows a comparison between a normal screw and a headless screw. So headless screw lacks a distinct head so that the head can be buried inside the cartilage so that the range of motion is pain free and cartilage degeneration is postponed. So these are the intraoperative images. So the femoral head fragment was completely without any attachment, it was lying free. So it was removed, freshened and fixed back with headless screws. So these are the post-op images. The other fracture requiring internal fixation was this proximal humerus shattered fracture. This was a neglected 16-day-old. The humeral head was locked anteriorly against the anterior glenoid. The proximal humerus was completely shattered. There was no scope of any reconstruction. So these are the CT images showing the same with additional coracoid fracture and scapular fracture. So it is next to impossible to reconstruct this fracture. So we planned for arthroplasty. So the arthroplasty which was done was called reverse shoulder arthroplasty. Now what is reverse shoulder arthroplasty? Why is it called reverse? So normally we have a ball and socket in the humeral joint. The ball is formed by the humeral head and the socket is formed by the glenoid. In reverse shoulder, the ball is being fitted on the glenoid side and the cup being the humeral side. So reverse shoulder arthroplasty is an excellent option for those with shattered proximal humerus with complete rotator cuff tear. So this is a total shoulder arthroplasty which is done in case of degenerative shoulder if the rotator cuff is intact. So this reverse shoulder arthroplasty is done for those who are rotator cuff deficient. They should have an intact deltoid. That is the only criterion. So this is the implant used for reverse shoulder arthroplasty. So these are the intraoperative images. This is the shattered remaining humeral head, intraoperative CM images and postoperative X-ray. So this is in comparison with the opposite shoulder. You can see a nice seated ball on the glenoid and a cup on the humeral side. The patient recovered her range of motions completely. She is able to walk, she is able to do all her day-to-day activities independently and she is pain-free both at the shoulder and the hip joint. So next case, it's a 28-year-old obese, hypertensive, already an ischemic coronary artery disease on treatment, presented with RTA. He had polytrauma and vascular injury. The good thing about it was he presented to us within 12 hours of injury. So these were the fractures: humeral shaft fracture, SI joint disruption, iliac spine avulsion, pubic diastasis, shattered forearm bones, and distal femur fracture. He had a previous surgery on the femur with a screw in situ and proximal tibia comminuted fracture. So this patient had a complete cutoff at the distal superficial femoral artery, 10 to 12 centimeter up to the origin of the popliteal artery. And the limb was not viable. Even though he presented within 12 hours, the limb was not viable. We did a fasciotomy, the muscles were totally unhealthy, not contracting. So we had to do a above knee amputation. And the other fractures were fixed on a staged fashion. The humeral fracture, forearm fracture, pubic diastasis and the iliac spine were fixed on a staged manner. Post-operatively, patient developed extensive pulmonary thromboembolism, which was detected efficiently in the ward. He was immediately transferred to the ICU where medical management was given, thrombolysis was given, and he was in the ICU for 1 week. And after efficient intensive management, patient recovered completely. So these are the follow-up images. Patient is able to stand erect with a prosthesis. So this is the hip and range of motion with the prosthesis on. You can see the prosthesis he is wearing, above knee prosthesis. He is able to do all his day-to-day activities. So next case, it's a 19-year-old college student presented RTA, run over by a truck with bilateral internal degloving. So this is the X-ray of the image showing a vertical shear injury of the pelvis. This is the image of the groin with internal degloving of both the thighs. Along with that, he had blood at urethral meatus at presentation. When we tried to catheterize the patient, we found blood. So we had called for the urologist suspecting a urethral injury. So patient also had shock at presentation. He had to be given a lot of colloids, fluids and blood resuscitation. So pelvic fractures are very prone for hemorrhage, internal bleeding. They can have a lot of blood loss. If not detected properly, we can even lose the patient. The source of bleeding can be the fractured bone ends, or it can be torn arteries or veins. After resuscitation, we took a CT scan which showed a sacrum fracture, which showed pubic diastasis with a vertical shear injury, and the mechanism in which the urethra gets torn whenever there is a vertical shear. So pelvic fractures are very prone for bladder and urethral injuries, since the urogenital system is closely associated with our bony architecture. Patient needed a suprapubic cystostomy, and external fixator for the pelvis was done, along with sacral screw fixation and the SI joint fixation on the opposite side. So internal degloving happens by a mechanism called moral level mechanism, which is basically a shearing injury in which the subcutaneous fat gets sheared off from the deep fascia, and there is lot of serosanguinous collection in between the two layers. If not detected early and if it is not drained adequately, the overlying skin can necrose, and this is very prone for infection. So this was the image at the initial presentation. After debridement, there was a drain which was inserted to drain the hematoma, but the overlying skin slowly started to necrose. So you can see the necrosis progressing. So the whole skin had devitalized, so it had to be removed, and it required a skin grafting. So to fasten the healing process, we had applied a vac dressing, and this is the image after. Promotes healing in multiple ways. So it provides a moist environment so that healing happens faster. It draws the wound edges closer. It removes the infectious material and edema. It promotes perfusion and granulation tissue. So these are the images at X-ray images at follow-up. Patient regained urinary continence after urethral repair. So these are the follow-up CT images showing excellent screw position and fracture healing. The joint alignment is also perfect. These are the 3D reconstruction images showing the same. So clinical photo on follow-up, patient is able to do all his day-to-day activities. Now he has completed his college and he has moved to Canada for further studies. So in the next case, it's a 19-year-old, again college student, RTA, presented to the ER within 12 hours of injury. He had acetabular fracture, femur fracture, and hematuria, along with absent distal pulses in the foot. So as in the previous case, this patient sustained a bladder injury since it is closely associated with the pubic bone. So you can see the images showing the fractured fragment injuring the bladder. So pelvis being richly vascular, there are a lot of rich anastomosis in and around the pelvis. The major vessels are also in the pelvis. So any bony injury can injure the major vessels, and it causes a lot of hemorrhage, and it can even lead to vascular injury. So this is the image of our patient which showed iliofemoral arterial occlusion right from here till here. You can also see the fractured femur. So this patient was successfully revived with a PTFE graft to bypass the thrombosed segment. So you can see the PTFE graft here and here. In the same approach, we had fixed the acetabulum. So the acetabulum was fixed, the femur was initially stabilized with an external fixator, and the bladder was also repaired. So in second stage, the external fixator was removed and femur nailing was done. So these are the images on follow-up. The patient is doing very well on follow-up. So next case, it's a elderly 61-year-old male, fall from height 3 weeks back. Again a delayed presentation, initially managed at government hospital. He had comorbidities, diabetes, anemia, along with pancreatic contusion and multiple fractures. So these were the fractures. Patient had D11, D12 burst fracture, fracture sacrum with SI joint disruption, left superior and inferior pubic ramus with anterior wall acetabulum fracture and pubic diastasis. These are the images showing the pancreatic contusion. So at General Hospital, they had managed the pelvic injury with the external fixator, and the humeral fracture was associated with wrist drop. So radial nerve palsy is very common in humeral fracture. So it has to be detected preoperatively and documented. So this patient was managed at GH only with a plaster. They didn't do any operative intervention. So in our hospital, we had realigned the external fixator, changed the external fixator, fixed the SI joint with the screws, and the radial nerve was explored and found to be intact, and the humeral fracture was fixed with a plate. In second stage, the external fixator was removed and pubic diastasis was plated. And in the same sitting, the spine was also stabilized with pedicle screws. So these are the images. Patient is able to walk. He is able to be ambulant in spite of being 3 weeks bedridden at the general hospital. He is having a wrist drop splint. He is awaiting the recovery of the radial nerve. So the next case, this case is not a trauma. So this case is slightly different. The patient is a case of cardiac disease with unstable angina, with comorbidities, diabetes and hypertension. She is an obese lady. She had a giddiness and fall and sustained injuries to the humerus and radius. So this is the ECG at presentation. This is the echo and coronary angiogram reports showing triple vessel disease. So these are the X-ray images showing the distal radius fracture and humeral shaft fracture. So in a single stage, both coronary artery bypass surgery, open heart surgery, and humeral nailing and distal radius fixation was done. So post-operatively, patient recovered in no time. So humerus was fixed with a nail, distal radius was fixed with K-wire. So this is the last case for the day. It's a 15-year-old school boy, history of run over after fall from a footboard of a bus. So it was initially managed elsewhere. Patient came with multiple skeletal injuries and perineal injury. So this was the image at presentation. Patient had a foul-smelling left thigh, which was grossly infected, poorly managed, with a grossly necrotic skin on the opposite thigh as well. He had a perineal injury, which was also foul-smelling, and external fixator was applied outside. So patient had a colostomy in view of perineal injury, and suprapubic cystostomy was done till the perineal injury completely healed. So these were the X-ray images on presentation. And this is the CT image showing shattered proximal humerus fracture, bilateral pubic rami fracture, sacrum fracture with the external fixator in situ. You can see the suprapubic catheter also in situ. So he also had a distal femur physeal injury. So close-up view of the sacral fractures and the pubic rami fracture. So on arrival, we had changed the external fixator pin because one of the pin was lying outside, which was done outside. So to stabilize the proximal femur fracture, we had to put a pin through the femur fracture. No form of internal fixation was possible because the overlying skin was all necrotic and infected. Only external fixator management was possible. So these are the X-ray and CT images after the surgery. And these are the wound images showing subsequent healing. So the grossly infected wound was debrided and vac was applied, and the whole area was grafted on both the thighs. Since the area of skin loss is more, and the patient also had bed sore since he was lying in the bed for a long time, so we had to manage with the available skin. So we had to use a skin graft measure. This helps in covering a large wound. By providing uniform meshes, we can stretch the graft and cover a large area of wound. So the calf also needed a skin graft. And this is the image of the boy. After complete recovery, he is able to pursue his school education. Now he has completed his school education. So trauma always requires a multidisciplinary team approach for successful management. So once again, elements of successful management include multidisciplinary team approach, timely diagnosis with all the available array of investigations, and appropriate intervention. I thank you once and all.
Dr. Balaji, regarding this Pipkin's fracture and internal fixation, how is the long-term follow-up What is the incidence of avascular necrosis in these cases?
I operated this case in 2018, sir.
Ah.
Now it is 2024. I recently saw the patient 2 months back. She is fine.
No evidence of.
Any avascular necrosis as of now.
Okay. Then in the other lady with humerus and distal radius fracture, do you prefer K-wire instead of plating? Distal radius.
Since it was a long surgery, cardiac surgery plus humerus bleeding was done, since the duration of the surgery had to be cut short, and the fracture also was amenable for K-wire fixation, K-wire fixation was done. Otherwise, if it was an isolated distal radius fracture, definitely plate fixation would have been done.
Thank you. Our second speaker for today is Dr. Barney Ratnavel. He specializes in spine surgery and has special interest in minimally invasive spine surgeries and spinal deformities. He completed his undergraduation in 2003 and did his post-graduation in MS Orthopedics in JIPMER, 2008 gold medalist. He is a member of the Royal College of Surgeons, UK. He did a fellowship in spinal deformity in Seoul, South Korea, from one of the world-renowned centers for scoliosis surgeries. A fellowship in geriatric spine surgery in Sendai Province, Japan, 2016. Fellowship in minimally invasive spine surgery in Michigan University, USA, 2018. He has worked as a teaching faculty in Chettinad Medical College as associate professor in orthopedics. Today, Dr. Barney will be presenting on geriatric spine problems.
A very good evening to one and all. I thank management of Billroth for giving me this opportunity to speak amidst you all. To start off, why this topic? Why old age related spinal problems? Because this one is slowly gaining more importance for, there is a rapid increase in number of geriatric patients approaching us. And general practitioners being the initial point of contact for elderly individuals, they tend to see more. And often these diseases are not properly evaluated or delayedly they are diagnosed in advanced stages, which directly affects the outcome of these painful pathologies. So let us understand what is old age. World Health Organization has clearly defined it as any individual crossing a chronological age of 60 is old or senile. The Americans have a different thought. They are old only when they cross 65 years of age for reasons better known to Americans alone. Still, they have a subdivision in their age category. Old age also they want to be defined as young old once they cross 65, and they don't want to get old till they become 85. This is better understood only by Americans. Globally, there is an increase in geriatric burden, and this is reflecting in India as well. Right now, 2022 statistics says we have 14% of the entire Indian population as geriatric category, and it's likely to increase. It will become 20% in 2050. So the demand on medical facilities is going to definitely increase. Interesting point here is 2/3 of these individuals will have one comorbidity or the other. And new insurance schemes, evolving government policies, and economic independence are helping them to access all these medical facilities which are available, and more people are seeking treatment for better quality. United Nations has definitely approached the World Health Organization to initiate programs to collaborate government sectors as well as private sectors to formulate programs that would celebrate this decade of healthy aging, which is from 2021 to 2030, which would promote longer and healthier life in this aging population. So an interesting study from 2017-18, which looks at the longitudinal aging that's happening in India. nearly 60% of individuals crossing 60 will have some requirement for a medical service in India. And out of that, 63% are seeking care in a private setup. And another national level survey at 2021 says Kerala is the country which has maximum geriatric population, and Tamil Nadu is second in the list. Top 5 geriatric illness, musculoskeletal illness, predominantly knee pain and back pain, is third in the list. And Tamil Nadu, 57.3% of treatment happens in the private setup. Why I am discussing this? Because we have a huge role to play in the care of these geriatric individuals. We shouldn't be missing out early diseases by under-evaluating them. So each symptom of an elderly individual needs to be thoroughly understood. They should be given time to explain themselves and evaluated early so that we can pick up certain diseases which are curable to a major extent nowadays. Going into the common problems that a GP is likely to see, most common problem is a back pain, followed by neck pain. It's usually a geriatric degenerative pain, followed by neurogenic claudication. I'll be explaining this term later. Due to two entities, stenosis as well as spondylolisthesis. And the other not so common complaint is weakness and gait disturbance. Fourth one is osteoporosis related problems, which can be a fracture, and not so common spinal infections and tumors, which we are seeing of late quite commonly. A quick look at the anatomy to understand what I'm going to talk now. This is the lower lumbar area, which is the most common site of back pain. We can see vertebral body is there, and in between the blue colored structure is the intervertebral disc, and in the back side we have facetal joints. These are the areas which take the whole body's pressure load. So with the aging, they degenerate and they become painful. So these are the sites which will throw pain, and they are understood better with X-rays and MRIs. Certain structures are not visible in X-rays. So when we are looking for a source of pain, a pain generator based on X-ray, we tend to miss them. So that is the reason why we need to consider bigger evaluation with MRI for painful conditions of the spine. So this categorization will help practitioners. So try to understand where the pain is. Most common pain is lower back pain, which anatomically is any pain that is present between the costal margins till the inferior gluteal fold. That is the area which we have to typically describe as lower back. Anything proximal to that between till the scapular blades is mid back, and anything proximal to that from the shoulder blade till upper scapular area is upper back. The reason why we need to know this is certain pathologies, quite sinister ones, like fractures or infections and tumors, are more common in upper back and middle back. So we straight away need to evaluate them with MRI. Whereas lower backs are generally due to degenerative disc diseases, for which we can evaluate them slowly with X-rays. We can subject them for physiotherapy. If not improving, then higher investigations. Generally, there is a thought among people, why consider higher imaging? We walk in with pain, 2-3 weeks pain, why should we consider an MRI? It's an expensive tool, and not many will be really happy to undergo an MRI. So we need to have a justification in that, and once we understand why we consider MRI straight away for some and why we delay it, that is the reason. And another way of looking at pain is classifying them as acute, subacute, and chronic pains. Chronic pains are persistent pains which remain there for more than 3 months, and they need to be evaluated with special X-rays, which involves forward bending and backward bending, that is flexion and extension X-rays taken in standing position. And they need to be evaluated with MRI. So any person with a long-standing pain, always start off with X-rays and MRI. There is no need to hesitate. We have set protocols for this. And any acute pain, even in elderly individuals, don't subject them for medicine straight away, followed by physiotherapy, because a lot of people tend to have tumors or infections which are growing in, and once they are subjected straight away to physiotherapy, they come with a bigger problem. So always start with X-rays, look for any lesions in the vertebral body, then ask for physiotherapy. If not improving, acute and subacute can be considered for MRI. So degenerative disc disease, commonly what we understand as spondylosis, is the most common reason for back pain, where the discs at single level or multiple levels can be bad, They dry up as one grows old, and this is picked up and diagnosed only with MRI. The commonly investigated investigation tool is X-rays. This is what we tend to see in an X-ray. There is loss of lordosis. This is the common report we tend to see from radiologists, loss of lordosis and disc space narrowing. What we infer out of this, not much. This is a change that is there in every individual once they reach 60 years. So will this show us where the pain is coming from? Not exactly. What we look for in our X-ray is there any gross destruction in the vertebral bodies or not? So these are age-related changes. They may be painful or may not be painful. So they need to be confirmed with MRI. So this is the typical degenerative change: disc space narrowing, osteophytes, loss of lordosis, sometimes subtle curve like what we are seeing on the other side, a scoliosis can be there. So to compare it with an young adult, this is the MRI picture. You can see in between the vertebral bodies where the arrow is showing, that is the intervertebral disc which has become black, that we call crenated disc. That is the source of pain often. A degenerated disc can bulge out towards the backside. It can press the nerves and cause radiating pain. So what do we do for this black discs which are seen in elderly individuals who present with only central pain which is not radiating to any nerves? We give them simple medicines. Usually it is paracetamol, 1 gram BD or TAD dose. If GA issues and renal perfusion issues are not there, we can consider even milder NSAIDs and subject them for IFT following an X-ray evaluation. IFT in shortwave, not more than 5 to 7 days. And traction nowadays, World Health Organization is in fact saying no for traction and LS belt for long-standing or even acute pains. So don't encourage your patients to have belt for more than 3 weeks. Local moist heat, activity modification in the form of restricting the duration of standing. They should be permitted to stand for less than 20 minutes or even sit for 20 minutes. Change of position helps during acute exacerbations. Core strengthening exercises need to be initiated at the end of second week. Nowadays, we are looking at initiating antioxidants as a treatment protocol for long-standing back pains, especially the drugs with superoxide dismutase is given for 2 to 3 months of duration. There is a significant reduction in the axial pain. We have sufficient literature to back this statement. Next comes the neurogenic claudication. This is another entity that one needs to understand. This needs an evaluation with MRI. This symptom indicates that the nerves are under tension. What is a claudication? It's a back pain which radiates. It's essentially a neuritic pain which starts in the back and radiates to both lower limbs and comes only on exertion. So closest differential diagnosis for this is a vascular ischemia or a vascular claudication, which is seen due to atherosclerosis in longer blood vessels. So we often investigate this with special X-rays, dynamic X-rays, and an MRI to understand how this nerve disc relation happens in the spinal segment. The blue colored structure is the disc. This is the diagram. And the yellow colored structure is the nerve which is coming out of the intervertebral foramen. So if the disc is bulging out or prolapses out, it can impinge the nerve. Now I would like to tell you the difference between sciatica and neurogenic claudication. This is one commonly used term. Sciatica is a term which we restrict to young individuals who present with disc prolapse and when the pain radiation is on only to one side. It is due to nerve root compression and it's a nerve root tension sign. Essentially, a single nerve root is under tension. So we have separate clinical tests to understand that. So whenever a single side radiation pain is there, document it as sciatica. And whenever both sides it is radiating, it's often claudication. So you can see here that the disc is prolapsing on one of the sides to one side, that is on the left side, the nerve is being pinched there. Common clinical tests for sciatica are these three. Straight leg raising test is the one commonly done. If you don't have a couch, simplest one is to make your patient sit and then try to extend the leg completely. If they are able to do this, then they are not having any root tension, which is what we expect in aged patients. When someone presents with claudication, these three tests will be negative. Simplest one, ask them to bend forward. If there is no radiation pain, it is not sciatica. And if they are able to do the straight leg raising test, which it's a passive test. Surgeon has to, or a physician has to do this. If they are able to do this, then the roots are not under tension. It means that the canal is narrow, and that's a stenosis. So that is the stenosis I was talking about. You can see a normal canal and a narrow canal where the disc from the front is bulging, and from the back facetal joints and certain ligaments are hypertrophied, and these are compressing the nerves. What essentially happens is the circulation to the nerves is compromised. So it doesn't happen at rest. Only when the patient exerts, walks for certain distance, this ischemia will set in and they will have radiating pain, and the patient will be forced to sit for some time. Again, they will walk for the same distance. So this cycle gets repeated. So this is a typical classical history, and these patients tend to bend forward as they keep walking. So these clinical parameters one can ask for and look for when someone complains of claudication. So that is the comparison there. Young individuals, single side pain when they are not able to bend or stretch their legs in sitting position, it is a disc prolapse that we tend to document as sciatica. Same thing, radiation on both sides, SLR negative is claudication in elderly. And simplest thing for practitioners to document will be, or even to assess them better, is to make them walk in your chamber. Make them walk on heel or walk on toes. This will bring about any kind of a paralysis that is setting in, because that directly indicates that the nerves are compromised, and we subject them for MRI straight away, and we plan interventions. So this is the simplest test to see if there is any neurological deficit. And check for peripheral pulses and order an MRI with whole spine screening with ultrasound assessment of KUB. Why KUB? So this is something that one needs to really appreciate, that the bladder innervation is from the lower lumbar segments, lower sacral as well as the lumbar segments. So any compression there in the lumbar segments can compromise the bladder innervation. So early onset of bladder weakness can be picked up by increased residual bladder volume, which is more than 40 ml. So, not to forget, elderly individuals can have even prostate problems. So this needs to be done as a regular protocol. So how do we treat stenosis? Again, in the same line as degenerative disc spondylosis. Simple analgesics, rest for 3 to 5 days. Rest means not complete bed rest. It's like activity modification. With physiotherapy, IFT and shortwave for 5 to 7 days. And neuromodulating drugs, gabapentin, pregabalin, amitriptyline are the commonly used ones. And brace for a shorter duration. LS brace is accepted here in neurogenic claudication for a shorter duration. Shorter is 2 to 3 weeks time. After this, what we initiate is back strengthening exercises. So prolonged usage of back belts, LS braces, can cause paraspinal atrophy. That itself can aggravate the back pain. That is the reason why we avoid prolonged suggestion for bracing. Epidural injection is another alternative which we suggest if patients are not improving by end of 6th week. Certain patients need surgery when the neurological deficit is evolving or when they develop bowel bladder disturbances. The commonest performed surgery is decompression, and the complex procedure what we sometimes address is decompression with fusion. So that is the protocol. NSAIDs, if the renal function permits, with pregabalin is much safer and much better alternative to just pregabalin. Paracetamol up to 3 grams is safe, and just watch out on the liver dysfunction. Ultrasets, semi-ultrasets are alternatives. Pregabalin, if used in elderly individuals with diabetic neuropathy, they can mask the underlying stenosis as well. So a quick look at the drug which is commonly seen in every prescription, any radiating pain, this is the drug everyone writes. A quick look at what it does. It modulates the calcium channel and reduces the release of certain substances which are excitogenic. And it has 7 clinical usages, out of which it is the drug of choice in 3 conditions: post-herpetic neuralgia, fibromyalgia, and diabetic peripheral neuropathy. These are the 3 indications where it is the drug of choice. So a diabetic patient can have spinal stenosis as well. So it's going to mask the spinal stenosis. So that we need to watch out. Probe such patients who are presenting with peripheral neuropathy for factors that aggravate their neuritic pain. How we give this? 75 is very safe dose to start. 150 milligram is the standard dose. 75 milligram as divided dose is generally prescribed. 1/5 of these individuals taking pregabalin have side effects in the form of drowsiness, and it is excreted unaltered through renal. Coming to another common entity that is missed that can cause stenosis. Spondylolisthesis is very common in aged individuals where there is a translation of one vertebral body on top of another. This is very often missed if we are not taking x-rays in proper position. The x-rays which will tell us that the vertebra is slipping is done in erect position, that is standing x-rays. So always make it a protocol of asking for standing x-rays in any elderly patient. Standing x-ray, sometimes even that itself without forward bending will tell us there is a translation or not. But ask for a flexion extension x-rays that will tell us about spondylolisthesis. So this is one entity. Why we need to know about this? This will not improve much with conservative care like medicines, injections, braces. Most often this will not improve, and often they'll end up having a procedure depending on the neurological symptoms. So what is the surgery advice for them? The procedure that we do for them is called transforaminal lumbar interbody fusion. This schematic diagram of interbody fusion. In the first image, you can see something painted in red. That is the disc which is degenerated and bulging out to the back. The area painted green is the facetal joint. These are the areas which change with age, which hypertrophy and compress the nerve and cause neuritic pain. These are completely removed. The disc is completely removed and the facets are completely removed. And we put titanium implants inside and we initiate something called as fusion by putting bone graft between these segments. This is the standard regularly performed procedure which has a success rate of nearly 98 to 99%. So to illustrate that, a case example, a 60-year-old lady who had a predominant back pain and radiating pain to both lower limbs, which changed with position. Her activities were restricted because of the pain. Her walking distance was 500 meters or even less. You can notice that this is the standing x-ray what I'm talking about. This patient was made to bend forward and bend backward. There is a translation that we can see there in the L3 vertebral body, seen by the yellow indicator indicates the level. So that is the L3 spondylolisthesis. This is the surgery, what I described right now. This is the transforaminal lumbar interbody fusion, T-lift surgery. Patient, generally they are mobilized within 24 hours. These surgeries, people are discharged in 48 hours duration time. Another common problem in geriatric category will be a neck pain due to cervical spondylosis. Similar to lumbar area, cervical segments also can have degeneration. The curious problem here can be a cervical cord compression that can happen in some percentage of individuals. It's usually less than 10% of people with spondylosis who develop myelopathy due to spinal cord compression. So this is often missed entity, spinal cord compression related myelopathy, because they present with vague symptoms in the hands. It can be a simple paresthesia or hand dysfunction, which a lot of people in practice tend to call it as neuropathy, diabetic neuropathy or some peripheral neuropathy. They evaluate it like that and then tend to miss out a bigger problem that is sitting in the cervical area. The way to avoid this is always ask for cervical spine screening whenever you advise an MRI in an elderly individual. So with a gradual screening, one view of screening, we can even look at their cervical spine. For a lot of people can have coexisting lumbar stenosis as well as cervical stenosis. This entity is called tandem stenosis. 10% of elderly individuals can have two segment stenosis. So we cannot address one segment and leave the other one to progress. Always watch out, ask for whole spine screening MRI in elderly individuals. So that is a case for you. That's a recently performed procedure. One 70-year-old male patient with high bilateral hand paresthesia. This man was investigated for neuropathy. He had underlying uncontrolled diabetes. He was evaluated for neuropathy and treated with pregabalin for longer duration. And by error or mistake, whatever you call it, he got an MRI done. That's when he found out he had this. When he started falling, he had started having gait disturbance, bowel bladder disturbances. They evaluated better with MRI. That's when we picked it. as you can see, that red colored structure is a thickening of posterior longitudinal ligament, which was completely ossified. This can be missed in X-rays. X-rays may not show this soft structure all that brightly. So we tend to miss this even in screening X-rays. So this was addressed by a posterior surgery where we removed the lamina completely. He is on his road to recovery now. This is almost a month back this was done. Coming to another common cause of back pain, osteoporosis related pain. World Health Organization again clearly defines it as a systemic disease, progressive disease, which leads to bone fragility and subsequent fracture. So when it is fragile, it can cause bone pain. When it fractures, there will be aggravation of pain. It's very common in postmenopausal women, and men, due to their hormones, they are safe from this till they are 70. Even trivial injuries can result in major fractures. An interesting point here one needs to understand is 2/3 of these individuals will not be having any symptoms. So one fine day they will come with fracture, which may or may not have neurological involvement. So main reason why we need to understand this is there is a very high increased rate of morbidity and mortality if these are not identified and treated early, this osteoporosis. Common fractures due to osteoporosis, hip injuries, spinal fractures, distal radius injuries. Spinal fractures can be multiple, and this often leads to reduction in height of an individual. They tend to walk with the stoop. So this is the cascade we are often worried about in a spinal fracture. If there is a fracture happening in one place, this whole spinal alignment gets altered. They tend to bend forward, and this itself can initiate a fracture at a different segment. So that's why we need to get aggressive and treat these individuals for osteoporosis whenever we encounter a fracture. So the fracture cascade, after an index fracture, up to 4 years, the risk of having another vertebral body having a fracture is 4 times, and extraspinal fracture is 2 times. So how do we evaluate them? With common X-rays, AP lateral views, MRI, and a DEXA scan. This needs to be given completely for any osteoporosis evaluation. Always include DEXA scan in your evaluation, because that will give us a score value predicting what is the fracture risk and what medicines we need to initiate for any individual. Of course, blood investigation needs to be done, including vitamin D3. That's the MRI. Why MRI for simple osteoporotic fractures? Aged individuals can have fracture due to other reasons as well. Commonest one will be a metastatic osteoporotic or metastatic collapse, which needs to be ruled out. That is better done with an MRI. That is the DEXA scan value which we look at before planning treatment protocols. It classifies bone into normal to severe osteoporosis. Osteoporosis is any T-score value less than -2.5. So we choose anabolics or anti-resorptives based on the T-score value, and the duration of treatment, how long to give calcium as well as better drugs for them, also depends on the T-score value. So try and involve an endocrinologist if things are too bad. If the T-score is too bad and you're not able to help them out, involve an endocrinologist, and in the presence of a spinal fracture, always involve specialists, because at times certain fractures heal with simple measures like braces, calcitonin. At times there can be worsening. So we have set protocols to identify which fractures will progress. I'll be showing you 2 cases for which standard protocols have been applied. One did well and one came with complication. I'll show you that. So the medical management from our end is going to be calcium supplements for 3 to 6 months duration, bisphosphonates or an anabolic parathermone analogs, depending on the T-score value, and vitamin D3 supplementation needs to be given. Simplest measure, whenever you encounter a fracture, osteoporotic fracture that is quite painful, always brace them up before you send them for a higher center or a specialist opinion. Initiate calcitonin spray for 7 to 10 days. And these individuals are considered for percutaneous procedures if they are not showing good clinical improvement in 3 to 6 weeks duration of bracing. So what are these augmentation techniques? Augmentation is insertion of cement into the fractured vertebral body, which gives immediate stability. We have 2 techniques. One is vertebroplasty, another one is a kyphoplasty. These are done in general anesthesia or even in local anesthesia, depending on the patient comfort and patient profile. So that is the first case for you. 81 years old with a trivial fall. She missed her stairs and fell down and had a back injury. In spite of bracing and adequate rest and analgesics, she was not showing any clinical recovery. So that is the X-ray initial presentation. We can notice that the L1 is fractured there, collapsed. And that is the procedure what we did for her. There is a kyphosis. If you can notice there is a anterior, in the front, there is an angulation, what we call as kyphosis. This kind of injuries can predispose to proximal level fractures in the future. So what we did is we attempted to reduce the kyphosis, reduce the bending by inserting a needle into that. And we have, through the second image, you can see that through a cannula we have pushed in cement, bone cement, which solidifies the fracture segment. So that is the post-operative image. There is a subtle correction there which has happened and it gave immediate stability. This patient was mobilized the same day and discharged the next day. There was no blood loss. This we did under general anesthesia for a lot of reasons. She had other high comorbidities and she was quite obese. She won't be tolerating it under local anesthesia. But then she was discharged within a day. It was a 6 millimeter stab incision which needed just a simple stitch. Another interesting case where things went wrong in spite of doing a kyphoplasty. This is one high demand individual, working lady who had osteoporotic compression fracture, postmenopausal osteoporosis, not treated well. She had a fracture which was subjected for a kyphoplasty. She came to us with this persistent pain in spite of fracture, augmentation with cements done in a well-reputed center. So that is the image she came with, an X-ray which showed a collapse, and on the angle what we surgeons routinely calculate at that junction where it has fractured is thoracolumbar junction, where we expect high stresses where we don't anticipate a kyphosis. For a kyphosis in the junction can predispose to further worsening or proximal fractures. We more often tend to restore the kyphosis at the junction. So this, in spite of a successful kyphoplasty, she tended to have a asymmetrical collapse, which was seen in the image AP and lateral view. That was a failed biplanar restoration. So what we did is an interesting procedure. We had supplemented the kyphoplasty with screws that were augmented with cement. So we have restored the kyphosis. If you can see the previous image, lateral view and the lateral view of this, you can notice that the angle with the kyphosis, anterior kyphosis, has been completely restored. Again, this patient was out of the bed the next day and she was discharged in a couple of days. The challenges in such scenarios is people tend to lose faith in the procedure. The index procedure has not helped her. So she being a high demand individual had a lot of questions whether this will help or not. So planning such a revision procedures in elderly individuals, taking risk and then delivering results was a huge risk, huge task involved in that. And to consider osteoporotic fixations also is not easy. Sometimes we need to fix multiple segments, involve special screw fixation systems. She is doing well. And the other case, less common reason for spinal pain is spinal tumors, which often is going to be metastatic lesion coming from breast, prostate or lung. They are initially evaluated with PET scan to understand the staging of the disease and CT guided biopsy to understand the grade of the tumor. Often they are managed with the help of a multidisciplinary team which will involve all kind of oncologists, medical, surgical as well as radiation. And we surgeons, spinal surgeons are involved when there is a clear-cut indication, like a progressive destruction which is not improving with chemotherapy or radiation, and when the tumor is found to be radioresistant, and when there is a deficit that is evolving, a quadriplegia or a paraplegia that is evolving, we tend to intervene. And generally the prognosis for these tumor-associated scenarios depends on the stage of the disease as well as grade of the tumor. Often the 2-year survival is not more than 20%, and breast and prostate tend to have slightly favorable prognosis. This is the case which we have done recently. In our setup, we had a patient, an elderly individual who had CA prostate who was on treatment with us. He developed sudden onset mid-back pain. So that is the area where we are often missing out in case we start off with X-rays. So we straight away did a MRI to identify if something is there. So we found a single metastasis there, MRI. So that was subject, since there was no deficit, we subjected that particular area for radiation. On radiation, this gentleman developed paralysis. He was slowly developing deficits and urinary retention was setting in. So we immediately took him up for surgery, where we have done a laminectomy and decompression surgery with stabilization. That is the image for you. First and second images are clearly showing that the vertebral body, whole vertebral body is replaced by tumor tissue. And the second image shows that the spinal cord is compressed completely by the tumorous tissue. So we have not debulked the tumor there because it's a palliative work. We have just decompressed the spinal cord and put screws into this particular involved segment. He was relatively pain-free in day 1. He was made to sit on day 2. He's wheelchair bound and then he's mobilized out of bed right now. He's showing signs of sensory and motor recovery, but it was quite slow. Not like an young individual where we anticipate recovery within 3 weeks. But a significant advantage what we found here was immediate pain relief, and we were able to get him out of the bed and avoid recumbency related issues. Coming to spinal infections, these are slowly becoming common. And whenever you encounter any diagnosis like a likely possibility of infection, don't treat them as tuberculosis. Not all infections in spine are due to TB. We are often finding pyogenic infections in elderly individuals in quite atypical areas as well. So whenever it is a junction, think of tuberculosis. Whenever it's away from junction, elderly, due to the comorbidities, they are prone for pyogenic infections. Staph, strep, E. coli, Klebsiella, and Pseudomonas, these are the commonly identified organisms nowadays. And do basic cultures, basic investigations like CBC, ESR, CRP, and ProCal. And commonly done one is MRI with a contrast to identify the extent of destruction and the extent of abscess. So we treat them with a CT-guided biopsy-based culture sensitivity report. See, biopsy will give us a clue about the organism, what we are handling. 6 weeks of antibiotics is sufficient enough. 4 weeks of oral. Prior to that, 2 weeks of IV is the commonly followed protocol. Surgery is restricted to people who have progressively increasing pain or when the vertebral body is destroyed or when there is neurological deficit that evolves. And the commonly performed procedure is posterior stabilization. At times when the destruction is more, we remove the entire vertebral body and replace that with a cage. This is a case illustration. 70-year-old lady with mid-back pain, treated for non-specific pain with physiotherapy. Based on X-ray, she was declared normal. She was given NSAIDs, relaxants, shortwave, IFT for 10 days. Due to some urinary disturbances, she was evaluated for UTI, treated for polyuria. Then when the right time came, she went for MRI. This was based on the suggestion by a neurologist when he was not able to club so many symptoms together. He randomly asked for an MRI. There it was sitting. D3 vertebral body was completely destroyed. There was an abscess. But atypical finding what we saw in this is the disc space were slightly preserved in that. So we had a differential diagnosis there. Is it an infection or a tumor? In an aged individual, both are relatively common. So we planned a CT-guided biopsy, which turned out to be inconclusive. By the time we were waiting for the CT report, this lady was slowly developing neurological deficit and urine retention, everything was slowly worsening. So we, with a working diagnosis of vertebral destruction, query caused with incomplete paraplegia, we took her up for a procedure. We did a laminectomy and pedicle screw fixation in her. The challenges here in operating in the upper dorsal segments, upper dorsal vertebral segment is the surrounding structures and the spinal cord. Here, the margin of error is 1 to 2 millimeter for placement of pedicle screws. Often we put these screws into the vertebral body with C-arm guidance, that is X-ray supports inside the operating theatre. So if these are not conducive, then we may not be able to place them in proper position. So margin of error should not cross 2 millimeters. If medially, if these screws are placed, they can hit the spinal cord and cause paraplegia. If laterally placed, these can injure the vital structures like the lung or even aorta. So that is the risk we play with when we are operating in the higher dorsal levels. This lady was quite obese, 92 kilos, and we had so many questions to answer and convince their relatives as well, because it was a deficit that was evolving. Cost, stay, and recovery chances, all these are quite and difficult to answer, especially the stay and the duration and recovery, especially when we are operating in higher segments, the chance of recovery also is compromised. So what we did was posterior stabilization and laminectomy and biopsy. So we got an answer for her pain. That was a tuberculosis. She was immediately out of bed the next day. We mobilized her in a wheelchair in 1 or 2 days' time. She was discharged in 5 days. So she is ambulant post-operatively. 1 month time she was ambulant independently. She had complete recovery and she is on ATT right now. Another interesting case, 75-year-old thin male individual who presented just with limb spasms and hand and feet paresthesia, again blamed on diabetic neuropathy. He had bladder urgency that was not explained, and so many medical issues that were investigated that delayed the MRI for his dorsal spine. So this is what we found. There was a D4 collapse, D4 vertebral destruction, again with same area, high dorsal area with the risks involved. We took him up for surgery for, he was worsening in terms of bladder function. That is the procedure we did for him. 75 years old, lean individual. So again, 75 years, convincing patient and relatives is a huge task. Lean mass individuals are prone for post-operative severe pain. This is an entity what we call as sarcopenia, where the muscle mass is compromised. So operating on such individuals again is another challenge. High dorsal surgery in a neurologically intact patient, again, considering that margin of error, we need to be really alert in operating on these. And C-arms didn't help. The C-arm was not even helpful in such placement. High dorsal placements, they are not very helpful. So to conclude, out of all these x-rays and cases what I've discussed, so there are some recommendations when to seek a specialist opinion. Simple pains, when not improving in 3 months' time, consider referring for an expert opinion. When there is a neurological deficit that is evolving, somebody is not even walking 500 meters without any pain, not improving with your pregabalin, gabapentin therapy, and when the MRI report clearly says the stenosis segments are less than 10 millimeters, and when you suspect infection or tumor, and when there is cervical involvement like a cervical myelopathy, hand dysfunction is setting in, consider taking a specialist opinion for your patients. And any patient with the known history of cancer, always take opinion. So I would like to conclude by giving you this take-home message. Elderly individuals present with lot of pains that are chronic, even though chronic, these are treatable if not curable. Stenosis in cervical and lumbar are not diagnosed unless we suspect that. Document pain intensity in every clinical visit. Pain intensity with VAS scale, and walking distance documentation. Never hesitate to over-investigate. Convince the patient that it's for their benefit you are doing this, and always do a dynamic X-rays and a whole spine screening image wherever indicated. Involve specialists whenever you are in doubt and when the patient is not improving in spite of your medications. And spinal surgeries in elderly are quite rewarding and they are quite safe. Thank you.
I'd only like to highlight one of the points by the speaker. Quite often patients with back pain are without diagnosis sent for physiotherapy like shortwave or interferential therapy. This is very risky. In case they, as he said, if they are having some tumor or infection, you are only going to aggravate the condition. So preferable to make a diagnosis and then send them for physiotherapy. Regarding this claudication, you have to differentiate between neurogenic and vascular. The symptom will be in vascular claudication, it will be a vice-like cramp. Whereas in neurogenic claudication, when they walk for some distance, they will have a sensation of pins and needles. This will help to differentiate between the two. Thank you. Then we'll go to the next speaker. Our next speaker this evening is Dr. Dore Rajan, Senior Orthopedic Surgeon and Specialist in Joint Replacement and Arthroscopic Surgeries. He completed his undergraduation from Madurai Medical College in 1989 and graduated MS Orthopedics in 1993 from JIPMER. He obtained a diploma in orthopedics and completed his DNB in the same year. He is Fellow of the Royal College of Surgeons, Glasgow since 1998. He holds a MSc Orthopedics degree from the University of Teesside, Middlesbrough, UK. After completing his higher surgical training in arthroscopy and arthroplasty through the years 1994 to 2000, he worked as a consultant orthopedist in Dubai, UAE from 2005 to 2007. Later, he joined Billroth Hospitals in 2007 and has been a senior consultant orthopedic surgeon ever since. He is a life member of Indian Orthopedic Association, Indian Arthroscopy Association, Indian Arthroplasty Association, and Indian Society of Hip and Knee Surgeons. Dr. Dore Rajan will now talk about the management of osteoarthritis in an evidence-based approach.
Thank you, Prem Kumar sir, for your kind introduction. And I have to thank the Billroth management for organizing this wonderful CME program today. And I should also like to thank to all those who are assembled here, sacrificing your Sunday evening time for the good cause. Now I'm going to talk to you about joint problems after having an elaborate lectures on spine and trauma by my beloved colleagues. This is the time for me to talk about the joint problems. And of course, we all have seen a number of joint problems in our daily practice. We would have treated a lot of problems in the clinical practice already, and some of you may have experienced it as well. So diagnosing the osteoarthritis is very simple. If you see anybody who walks into the clinic or walking on the road having antalgic gait or waddling gait, you can doubly be sure that you can very well say that they have osteoarthritis. Now, osteoarthritis, the treatment of osteoarthritis, there are different treatment options available, and these treatment options are based on the clinical guidelines. And there are several guidelines which were proposed by these international organizations, ORC, NICE, WAOS, American College of Rheumatology, and the European Society. These clinical practice guidelines are just recommendations for making clinical decision based on research evidence. So this helps the clinicians to take a clinical decision on treating the patient. And these clinical decisions are good, and they actually tells you an effectiveness of a particular procedure, but it doesn't help you to, they doesn't tell you whether the procedure is very helpful to a particular patient or not. So from patient perspective, these clinical guidelines, they don't really help. So it's not actually a one-size-fit-all solution for this treatment of osteoarthritis. So we have to depend on what is called as evidence-based practice. So what is evidence-based practice? Evidence-based practice is this is actually a process by combining the current scientific evidence with patient perspective and clinical expertise to make a clinical decision to treat a particular problem. To tell you an example, let's say that a 75-year-old gentleman coming with severe arthritis, having severe pain, and tried all the treatment available, and he has got a higher untreatable medical comorbidities. So if you follow the clinical guidelines, you would say that this patient will need total knee replacement. But if you look from evidence-based angle, then probably you would not operate or you will not offer total knee replacement for this patient because of the complications of TKR in these patients are very high. So coming to the epidemiological status of osteoarthritis, the statistics says, according to the WHO, 595 million people suffer from osteoarthritis, and it is expected to reach 1 billion by 2050. 344 million people will suffer from moderate and severe arthritis needing treatment. The figure at the bottom shows that there is increased incidence of arthritis in these areas where it is shaded purple, which is North America, Canada, and also in the European countries. Osteoarthritis has become an important problem, public health concern already, and this figure shows that there is increased incidence of prevalence of osteoarthritis in various states. The states which are shaded red has increased prevalence of osteoarthritis. The prevalence of osteoarthritis is 50% and is keeping rising, and there is increase in aging. This is due to in our country, because of our population is 1.3 billion, there is increase in aging population and also increase in the life expectancy among the people. Already there are 23, there is increase in prevalence of osteoarthritis from 23 million to 62 million in 2019. OA is found to be higher in females than in males. Age, BMI, which is body mass index, socioeconomic status, urban living, employment status are also associated with the prevalence of osteoarthritis. Let us take a clinical scenario, which is a 65-year-old lady who came with the pain in both lower limbs for the past 3 months, and she was having pain on, and it was a very difficult knee replacement because there was a varus deformity and there was a bony destruction. So we have to put in some bone grafts over here and fix it with bone screws. It's not a straightforward knee replacement anyway. And she had a very good result subsequently. Osteoarthritis is not just a degenerative process as we all say, but there is some inflammation at a molecular level. So usually osteoarthritis starts from the cartilage and then it spreads to the other areas. Unlike the inflammatory arthritis, which starts from the synovium and then it goes into involve the cartilage. The pathophysiology is there is macro and repetitive micro trauma occurring during everyday daily activities, and this causes the release of pro-inflammatory mediators, which are cytokines, and this causes destruction of extracellular matrix, and along with that, abnormal mechanical forces causes further destruction and new bone formation and subsequently deformity. So this is a pathophysiology of osteoarthritis. And this, now you can see the microscopic appearance of a normal cartilage and a destroyed cartilage. In destroyed cartilage, there is absolutely no extracellular matrix and cartilage layer. And the destruction has gone up to the subchondral level. And that is called as hibernation of bone. Cartilage is actually an aneural structure and avascular structure. So there is no way that the patient can have pain in early stages of osteoarthritis. So that's the reason why we find a lot of people with radiographic osteoarthritis but no symptoms. And once the cartilage destruction happens up to the subchondral bone and bone marrow, then the patient starts to develop pain. Or sometimes you may have inflammation of the synovium and that causes pain. Then sometimes you can have effusion inside the joint and that causes stitching of the joint capsule, and that also can result in pain. And it may also be associated with neuropathic symptoms if these osteoarthritis persists for a longer period of time. So as I already mentioned, the radiographic osteoarthritis does not correlate with the symptoms, and only 15 to 81% of individuals with radiographic osteoarthritis have pain. Our patient with arthritis have 4 to 5 times more likely to have fall and injuries. This is very well documented, and we find all the patients who come with the fracture neck of femur, majority of the cases, they have osteoarthritis of the knee. Why it happens is because in osteoarthritis, there is instability in the knee joint, and along with that, there is muscular weakness because of disuse and also deformity. So all these three factors combine together and can result in fall and injuries. So that's the reason why we should treat osteoarthritis earlier before it gets to the stage where they have fractures, and that will lead on to other complications. And this fracture which you can have is a neck of femur fracture or a fracture below the knee joint in the metaphyseal area. I have a clinical case here. This lady actually is 75-year-old. She came following a fall, and she had a fracture of the femur bone, shaft of the femur. And when we took an X-ray, the patient also had severe osteoarthritis over here, and she had a very severe deformity and bony destruction. So just treating a fracture in this case may not be a good idea. That's why I asked for. I convinced a lady to undergo total knee replacement in addition to the fixation of the fracture. So she underwent the total knee replacement along with the nailing of the fracture, and now she is back on her feet. This is another lady who came with pain in her knees, and when we took X-ray, the patient had osteoarthritis of knee, and she didn't have any fall at all. But on screening the femur, there was a stress fracture in the shaft of femur. So this shows that it's very important to take full X-rays of the knee and the tibia for a patient who comes for knee replacement or osteoarthritic treatment. And this patient underwent the same combination of total knee replacement along with the nailing of fracture. And now she's again back on her feet, doing well. It is very important to know the risk factors for osteoarthritis because management of the risk factors in early osteoarthritis will help in arresting the progression of osteoarthritis. So there are two type of risk factors. One is non-modifiable and another one is modifiable. The non-modifiable risk factors, we can't do anything about it, so nothing can be done. Those non-modifiable risk factors are age, and as we know that osteoarthritis occurs in the elderly population, and of course it is not true. You can also have osteoarthritis at an younger population, even at the age of 40 years. And when it comes to sex, females, they have higher incidence of osteoarthritis compared to male population. And ethnicity is the race. The osteoarthritis is very common in Africans and Asians. And there is a genetic predisposition to the prevalence of osteoarthritis, especially with spine osteoarthritis and hand osteoarthritis. Previous joint injury predisposes the individual to develop osteoarthritis of a particular joint. So it is important to treat if there is any injury to the joint, or if there is any associated ACL injuries, anterior cruciate ligament injury or meniscal injury. We should treat them because we can arrest them to have osteoarthritis in the future. And coming to the modifiable risk factors, this is very important because when we can do something about it so that we can arrest the progression of osteoarthritis. So excessive weight is an important risk factor. BMI of more than 30 degrees, there is 2 to 4-fold rise in the risk of osteoarthritis. Both metabolic and mechanical factors play an important role in the causation of OA. When it comes to heavy jobs involving prolonged sitting, squatting, lifting, kneeling, and repetitive motion can lead to osteoarthritis. High impact professional sports like running, jumping can also increase the incidence of OA. Proper precautions like stretching and strengthening exercise would help in preventing the onset of OA. Joint injury prevention can be done by neuromuscular training exercise. It can reduce the incidence of OA by 70%. Malalignment of knee can lead to osteoarthritis is well known, either genu varum or genu valgum of the knee. So by correcting the deformity by using knee braces or shoe insert or osteotomy procedures, we can control the onset of osteoarthritis. And muscle weakness can be arrested by quadriceps strengthening exercises. The standard X-rays taken for knee osteoarthritis are bilateral weight-bearing AP view, bilateral weight-bearing PA view, lateral view, and patella skyline view. Why weight-bearing X-ray? Because weight-bearing X-ray only we can assess the joint space width, because it's a very important measure in grading the severity of osteoarthritis. Rosenberg view is another very important X-ray which not many people will do. It's basically a weight-bearing PA view. It's done with a knee in 45 degrees. And this Rosenberg view is very sensitive for detecting the joint space narrowing in early osteoarthritis. Kellgren-Lawrence grading is used for classification of osteoarthritis knee, and this was introduced in 1957, and this is still being used. This has got 4 grades. Grade 1 is minute osteophyte and a doubtful narrowing of joint. Grade 2 is definite osteophyte and normal joint space. Grade 3 is moderate joint space reduction, and grade 4 is greatly reduced joint space, subchondral sclerosis, and presence of osteophyte. In our country, we see this kind of X-rays very common. This probably is the severest form of Kellgren-Lawrence grading system. MRI is not recommended for osteoarthritic diagnosis. When we do MRI only when we suspect meniscal injuries. And in the presence of a meniscal injury, especially the posterior root of medial meniscus can be injured by a trivial trauma in a patient with osteoarthritis. So the treatment will be focused on the treatment of meniscal tear rather than osteoarthritis. And degenerative meniscal tear, which we commonly see on the MRI reports, can mislead, can cause confusion as well. The treatment goal is first is management of modifiable risk factors, which can slow down the progression of osteoarthritis. The primary goal is pain relief and improvement of joint function. So basically the treatment of osteoarthritis, there is no cure for osteoarthritis, and the treatment rely basically on the symptomatic improvement. The non-pharmacological therapy in osteoarthritis given by the WAOS is NU. NU is nothing but is a mnemonic for activity modification, NSAIDs, exercise, and weight management. So activity modification is just adaptation of the individual to cope up with the disability and to maintain the physical activity. So basically, we can avoid high impact activities and encourage cardiac exercise for this type of individuals. And activity modification otherwise is that sometimes we can use cane while walking or using rails while climbing the stairs. So these are the activity modification one can do basically before going for the other treatments. NSAID is a first line drug advised by many international organizations, and basically the NSAID are effective during the pain flare-ups. 2 types of NSAID one can consider, selective and non-selective. And selective COX-2 inhibitors have advantage over the non-selective in terms of gastrointestinal tolerability. And cautions should be exercised in patients with renal problems and cardiovascular problems. And NSAID should be used in lowest dose for a shorter period of time. And sometimes topical NSAID is also very safe and effective. Acetaminophen, which is our paracetamol, has got very few risks and it is well tolerated, especially in the elderly patients. And opiates, which is commonly tramadol, is used where there is a contraindication for NSAID use, with a warning that addiction can occur on long-term use. Improvement in strength and proprioception may reduce the disease progression and fall risk in osteoarthritis. So strengthening exercises, cycling, swimming, and aerobic exercises can be advocated. Reduction of weight certainly has improvement in pain and function in osteoarthritis. It has been clearly demonstrated, especially if BMI is more than 25. Framingham study in 1992, which is a very famous study, showed a decrease in BMI of more than 2 kg, achieved 50% reduction of pain. Another trial called ADAPT, Arthritis Diet Activity Promotion Trial, showed a significant improvement in pain and function after modest weight reduction. The unloaded braces are really helpful in reducing the pain and function especially in medial osteoarthritis. And this is used especially in active patients who needs pain relief for specific weight-bearing activities. And they are also, if they are not ready for surgery, or those patients who are unfit for surgery. The problem with usage of braces or poor compliance, and there is lack of symptomatic relief, discomfort, and skin irritation, and poor fit, etc. Glucosamine and chondroitin sulfate, they are called nutraceuticals. They are otherwise classified under symptomatic slow-acting OA drugs. So these two, glucosamine and chondroitin sulfate, are the natural constituent of cartilage, extracellular matrix, proteoglycans. So many studies have shown that there is improvement of pain and function by 28% in a study by Tovid et al. In 2005. Another GATE study has also showed a very effective improvement in pain and function than placebo in moderate and severe OA. It's really a safe drug anyway to go for, but it is still not US FDA approved for the treatment of osteoarthritis. Another drug is collagen, type 2 collagen low molecular weight peptides. This is actually also part of the cartilage extracellular matrix. It exerts counterprotective function. And these collagen peptides actually cause improvement in pain and function in various studies. And safety is also proven to be very safe. This drug is proven to be very safe. And this drug is also not US FDA approved for the treatment of osteoarthritis. Corticosteroid injection, intraarticular injection, is a very effective way of relieving the pain, and especially the short-term pain relief is achieved by intraarticular injection. And this has been proved by many studies. And this type of treatment is indicated in patients with KL3 and KL4, and also patients who are yet to become surgical candidates or patients who decline for surgery. The main contraindications are infection or patients who are going to undergo replacement in less than 6 months' time. The side effect is that when you use a repeated corticosteroid injection, it can cause cartilage volume loss and it can accelerate the osteoarthritic progression. Hyaluronic acid is another injection which can be tried. It's a low molecular weight glycosaminoglycans found in the synovial fluid, and basically it is a lubricant and it offers counterprotection. It has anti-inflammatory activity action, analgesic, and it enhances synthesis of proteoglycans and glycosaminoglycans. And this can be used in patients with mild and moderate osteoarthritis. Studies from Cochrane review showed that there was superior efficacy of this hyaluronic acid injection up to 13 weeks. However, meta-analysis on this HA injection found no clinical treatment benefits considering the higher cost of this injection, because this cost of the injection is very high. So the amount of benefit which we get out of this is not very significant. And also the systemic reviews which support the HA use up to 6 months in osteoarthritis following PRP injection. And 3 injections are advocated than single injection. Now there is again a bit of controversy over here. There are papers which found there was no difference in pain following 3 injections of PRP. Only functional improvement have been noted after 6 months. And clinical effectiveness, so the clinical effectiveness of PRP is still unproven because of variability in outcome in different studies. And important reason for this variability is the PRP preparations are different, and the concentration of platelets in each PRP preparation is different. So that's the reason why the different studies had different outcomes. The another biological substance which we can try is a mesenchymal stem cell. They can be harvested from the bone marrow or from the adipose tissue. The mesenchymal stem cells have in vitro ability to differentiate into various cell types and also has immunoregulatory properties. But this understanding is inadequate regarding the physiological and cellular function in vivo studies, because this has not been demonstrated as you know that this has been demonstrated in various studies as well. Total knee replacement is the most common procedure done in the world. Over 1 million procedures have been done per year. The survival rate for total knee replacement is found to be 82%, and total hip replacement is 80% for 20 years' time. According to the Indian Joint Registry, more than 80,000 knee replacements have been done every year. The figure at the bottom shows that the countries of Asia Pacific region, there is increase in the number of joint replacement. The countries are in the Asia Pacific regions are India, China, and also Australia. There is increased number of joint replacement being undertaken in these countries. Which patient should receive joint replacement surgery? Patient with pain and improvement of function who are refractory to medical and injection treatment, and patient with severe radiographic changes and functional limitations. These are two of the key deciding factors in joint replacement. So selection of patients should be very strict and stringent, because there is an incidence of a report of 20% unsatisfaction among the total knee replacement patients in few studies in the literature. When one side of the joint is affected, you can consider partial knee replacement instead of total knee replacement. And this is a very good procedure because of the fact that this actually mimics a natural knee. This is considered in patients who have low demands and also age more than 60 years. And this partial knee replacement can be done for both medial compartment and lateral compartment. This mimic normal knee kinematics. It has less postoperative pain and less complication and good knee function. The survival rate of partial knee replacement is found to be 91% in 20 years' time. And this is a case of a severe osteoarthritis with a varus and flexion deformity. This gentleman is from Africa. He came with severe pain and deformity in both knees, and he was unable to walk on his own for 2 years, and he could barely walk a few steps. And this gentleman was fit and he didn't have any comorbidities, so we decided to go for a knee replacement surgery for this gentleman. So he underwent this knee replacement surgery in a single setting because of the fact that he was fit like a fiddle. So after the surgery, this was before the surgery, he could hardly walk without the support of another person. You can see how severe the deformity of both his knees are. And after the surgery, he could walk with walker straight away in the second day onwards. So this is showing how effective a knee replacement can give a patient the improvement in function and also the pain. Since the advent of replacement in 1962 by Sir John Charnley in UK, there has been a developments in the hip knee replacement over a period of time, and that has improved the outcome and reduced the complication and improved the implant survival rates. The advances in the joint replacement have been done on the materials used, method of fixation, design of implant, joint interface, and component implantation technology. The materials are used in joint replacement are cobalt chromium alloy commonly. Titanium alloy is also being used, oxynium alloy, titanium niobium nitrate, and ceramic alloys. The design of the hip replacement and knee replacement also had undergone changes over a period of time. The method of fixation is either cemented fixation or an uncemented fixation. Cemented fixation is ideal for osteoporotic bones, and uncemented fixation is ideal for younger patients. Titanium niobium nitrate is otherwise called as gold knee because of its appearance. And this is basically the coating on top of a cobalt chromium alloy. And this alloy is very useful in patients with reported metal hypersensitivity. A similar outcome and survivorship have been found out, noted in different art papers. So this is the titanium niobium nitrate knee replacement. And another alloy is oxinium alloy. It's nothing but oxidized zirconium. And this is also used in patients with hypersensitivity. And this also had shown a similar outcome and survivorship in many studies. Ceramics, alumina and zirconia are the two ceramics used in the joint replacement. These two ceramics implant material have shown very good results in terms of wear and hip replacement. Clinical outcome and survival rates are found to be comparable to the conventional implant. Instead of one articulation, there are two articulations in this type of hip replacement. There is dual mobility. It's called dual mobility articulations. The dual mobility articulation decreases the wear rate and the dislocation rate, and this allows a greater range of movements. And this type of articulations can be useful for revision surgery and complex primary hip surgery. Patient-specific implant is another new technology using 3D technology in hip and knee replacement. Here, is especially useful in complex primary and revision replacements. When there is a severe deformity or destruction of bone where the normal implant cannot be used, one can go for this type of technology. We have a case where this patient, 68-year-old lady, had infection following hemiarthroplasty done elsewhere, and because she neglected it for a long period of time, the acetabulum has become like a ballooned inside the pelvis. It's called protrusio acetabuli. And because of the infection, we have to remove the hemiarthroplasty. And once the infection was subsided, she wanted to have the total hip replacement. So when we are assessing for the replacement, we found there was a huge defect in the acetabulum, and there was no way that the normal implant can be fitted in the acetabulum defect. So we went for a CT scan of that particular area and made a 3D 3D bone model, and with the help of computer software, we designed an implant, a custom-made implant, which can fit exactly the defect in that area. So once that model was done, we made an implant using titanium, and that was implanted at the time of surgery, and on top of that, hip replacement was done. And this is her post-operative X-ray. And she is doing very well, and I'm sorry, I don't have the post-operative films with me. The computer navigation is another technology where it helps in the joint, helps the surgeon in having a joint alignment, better implant positioning, and component sizing. This is good for extra-articular deformities and also good for surgical training. The robotic-assisted knee replacement is something new. This is nothing but the extension of the computer navigation. In computer navigation, basically the surgeon will do the knee replacement with the help of the computer information. Whatever information the computer tells, the surgeon will do the surgery. But in robotic-assisted knee replacement, the robotic arm will do the bone cuts. Basically, the bone cuts is actually 25% of the surgery, and the rest of the surgery is done by the surgeon. But it comes with an additional cost. That's the problem. It gives really an improvement in the accuracy and also precision of knee replacement, but again, it comes with an additional cost. Because by understanding the pathophysiology of osteoarthritis in the knee, there are several research is going on for identifying a new molecule, and basically the molecules are targeting the articular cartilage. Anabolic drugs and anti-catabolic drugs are available. Regenerative therapies like MSCs or adipose stem cells, and therapies targeting subchondral bone, bisphosphonates, denosumab, teriparatide, and therapies targeting the inflammatory pathways, TNF antagonist, and gene therapy, interleukin-1 antagonist, and pain therapy, anti-nerve growth factor, and statins for metabolic syndrome, and therapy targeting aging, cell cycle inhibitors, redox signal pathways, antioxidants. So these therapies are still in experimental phase. Maybe it will be available on the horizon. The take-home points are there is no effective cure for osteoarthritis yet. We only manage the symptoms. And osteoarthritis is rapidly increasing, especially in our country, because of increasing in aging population and also lack of exercise and obesity. Prevention or delaying the onset is a key. Management of risk and predisposing factors should be the most important part of the intervention. Treatment should be patient-centered and not surgeon-centered. And patients who continue to have pain and disability in spite of conservative treatment, surgery should be offered. Regenerative therapy is still on the experimental phase. Computer and robotic technology are costly and has not proven to give better outcomes compared to the conventional technology yet. So we have to still wait for the outcome studies. Conventional joint replacement is still a successful procedure in terms of pain relief and function. So I thank you all for kind attention.
In the case of obese patients, what do you have any weight limit beyond which you don't do the surgery? You ask them to reduce the weight and come.
So usually BMI of more than 30, certainly I would not discourage have a total knee replacement more than 30, the morbidly obese. But again, having said that, if you ask a patient to reduce the weight, it's very difficult for a patient with severe osteoarthritis to reduce the weight. So sometimes we end up in doing a knee replacement, and there are studies which shows that there is no impact on the outcomes in obese patients undergoing knee replacement.
Yes, probably by using in one of your slides I saw a long stem tibial prosthesis that will help in obese patients and osteoporotic patients.
Absolutely, absolutely. So long stem processes are useful in patients with osteopenic bones and also in obese patients where an extra load can be taken by the stem.
Thank you. Our next speaker for this evening is Dr. T.V. Raja, senior orthopedic surgeon who specializes in foot and ankle surgery and diabetic foot management. He completed his MBBS in 1991 from Raja Muttaya Medical College, RMCCH. He obtained his diploma in orthopedics in 1996 from Jawaharlal Nehru Medical College, Belgaum, Karnataka. He got his diploma in foot surgery in 2005 from Bordeaux, France, and has done MCH orthopedics from USAAMS. Dr. Raja is the managing director of Visa Medicure, foot and ankle specialist since 2006. He is the president of the Indian Foot and Ankle Society and a member of the Diabetic Foot Society of India. Today, Dr. T.V. Raja will enlighten us on limb salvage of Charcot foot.
So today's topic, I first thank the Billroth team for giving me this opportunity. One of the rare topics and my common topic is limb salvage in Charcot foot. So you heard the topic that everybody talked about as 80,000 joints per year in the Indian registry, but there's no registry for Charcot's foot because half of the patients today in India go in for amputations. So we thought how we could save, and we've got a registry now in Indian Foot and Ankle Society. to record the number of Charcot foot that is presenting. Half of the Charcot foot is seen by plastic surgeons and then by general surgeons, and rarely it comes to orthopedic surgeons at the last. So there are a lot of etiology for Charcot foot. One is a neurovascular theory, another was a neurotraumatic theory. So what is a normal clinical feature they present with? They'll come with you with a small fall or a sprain and trauma. And normally they are painless because it's because of their diabetic neuropathy. And normally it is a unilateral limb and they have a rocker bottom foot. If you find it early, this is a normal, your approach, how you have to manage. We'll go fast because your dinner time is starting. This is the classification. Cella Barrett, we keep following it. Normally they present like a cellulitis or osteomyelitis or a DVT. Normally everybody suspects it for cellulitis and it is misdiagnosed as cellulitis. Normally the tarsomeridal joint involvement is 60%, MTP joint is about 30%, and tarocrural or your ankle joint is 10%. Common conservative management, what you can do is a total contact cast with an offloading. When it goes on still more worse, you go in for internal fixation with plate and screws. With bone grafting, then you have intramedullary fixation, you have beaming screw fixation, and the last one is the Elizarov. Normally everybody does a offloading, you put them on a below knee cast or a custom wear footwear, and the ulcer heals, and you can supplement with a bisphosphonate treatment. This is the total contact cast. This is very, very important because it offloads your foot and you will be able to walk better with this. The wound normally heals, any ulcer in the plantar aspect heals in about 3 to 4 weeks time, and then you can give them a crow walker and make them walk. This is the crow walker which is used in all the Charcot's foot to make them mobilize after the wound heals. So normally if it is not healing, they come to the surgeon and they go for debridement and fixation. So this is the latest thing that has come, where your axial load is converted into beam mechanism and then the foot goes in for union, and this is called beam fixation screws. This is the concept of beaming. Normally you beam the medial column, lateral column, and the subtalar area. This is one of the oldest cases that we have done. This is the medial column, lateral column screw fixation, and then your subtalar fusion. Okay, a case like this comes to you, you do it. If suppose it fails, what do? This is a case 60 years old, was done elsewhere with a beam screw. There's a catastrophe, 120 kilo lady with about 62 years old. So what do you do next? Refer it to your friend or refer it to a higher center is the question there. So what else you can do? You can do an amputation, or if you want to salvage the limb, what are the methods to salvage the limb? The idea is to save the foot for the patient, which is very, very important. So it is nothing but sharing of knowledge and sharing of my experience on the dais. No contradiction with any modality of treatment. Success and failure both are 7-letter words, but decision making is very, very important. So the advantages of Elizarov fixator in a Charcot is to limb salvage, prevent the amputation, improve the activity level of the patient, prevent a recurrence of ulcer, and provide a planty-grade ulcer-free foot. There are a lot of publications that's come out where you compare internal fixation versus an external fixator. The external fixation always proves to be better compared to an internal fixation, because the internal fixation, until there is a bony union, you will have to keep them on a splint or a non-weight bearing. Whereas it is Elizarov, you can make them early weight bearing in about 3 weeks. A lot of comparative studies are there, and internal fixation is about 6.8% successful, whereas in an external fixator on a Elizarov is 13%. That's the odds. So how I do it, I'll show you. These are the equipments. This is the case that I saw a couple of years back. We have removed all the screws, put on Elizarov, and made them, attempted a pantalar fusion and made them walk. She walks on end of 3 weeks with a walker, 120 kilos. So this is another case, 63 years. We attempted for an internal as well as an external fixator. This is removal of ring fixators. You can see the bony union there in the midfoot. You can see him walking with a air walker. Another case where you can see the medial column, medial cuneiform out, made a small wedge, opened up the medial column, stabilized with internally as well as on ring fixator. You can see the medial cuneiform was already gone in, midfoot attempted fusion with a plate and screws as well as with a ring fixator. You can see her walking. With the air walker. Here, after removal of the air walker, you can see the lady walking on the other side. And half of these patients were advised below knee amputation. Very sad. There's another case, a 5th metatarsal base fracture, got treated elsewhere, landed up in a Charcot. We went in for a fusion, and he had a little bit of varus, accepted the varus and mobilized him. You can see him even walking there. Here, closed arthrodosis in an infected neuropathic ankle. There was a study that was done. Here, they have not even denuded the cartilage, went for a Elisarov ring fixated and started compressing. And the group had about 80% success rate, and group which denuded the cartilage had 100% success rate. It's another case. This is the condition he came to me, staged the procedure, had a primary debridement, then went on ring fixators. That's a ring fixator. You can see the wound healing there. That is the X-ray pan-talar fusion. You can see him walking with the fixator. This is the post-op. You can see a fibrous union there. But you see the next X-ray, the lateral column would have got united. That is the present photo. About a month back I saw him. You can see the lateral column there going in for a union. So in a limb salvage, you always not expect for a bony union. You can even accept a fibrous union and allow them to walk on a crow walker for about a year or so. You can see him walking without anything now, the same patient. This is another case, 44 years old, abroad, landed up with a midfoot charco with a calcaneal osteomyelitis. You can see, I approached from posteriorly, you can see the sinus there from the midfoot coming to the calcaneum. Put him on ring fixators. That is the post-op image. You can see him walking with a PTB there. I have removed the PTB, he is on a crow walker. This is another case, 50 years old. You can see the amount of damage of the bone there on ring fixator. So the next option without a ring fixator is a retrograde intramedullary nailing, or we call it a TCG nail. What happens when you do it? Get a good solid union, but the chances of infection in a diabetic foot is very high. So there's another lady who went for a nailing, but she didn't land up in a good union, got infected, was replaced with a still more longer nail with bone grafting, again infected, came to me, we removed everything, put her on a ring fixator, all the wounds debrided. That is the post-op. Now she's walking with a crow walker. This is another case. There you can see the midfoot charco with the osteomyelitis of the calcaneum. On ring fixators, that's it. This is another case where you can see the talocrural fully gone. This is that patient where he walks post ring fixator removal, barefoot walking. Even they have fibrous union, I do accept it because it is limb salvage. There are two-stage percutaneous approach. I've started doing this also because I'm a minimally invasive surgeon. So I'll show you a case where we have done it. This is a posterior arthroscopy. We've debrided the talocrural angle, put her on ring fixators. That is the case. Young lady, you can see, I've got a pin here through the trans calcaneum, which I removed at the end of 3 weeks and make them walk. That is the union I've got after the removal. You can see her walking here. So imagine all these patients going in for below knee amputation. So this is the midterm walking ability after a Charcot on Elizarov is very high. 96.3% patients have limb salvage, and they all are independent and mobile and ambulatory after a radiological fusion. So normally my post-op protocol is I remove the tibial pins in about transcalcaneal tibial pins in 3 weeks, partial weight bearing after 3 weeks, transarticular compression every works done was from 8 to 10 weeks, dynamize the rings before 3 weeks of removal. 4-foot ring removal normally I do before dynamization, antibiotic cover depending on the infection for 6 weeks to 8 weeks with the ID specialist. Concurrence, all patients were on bisphosphonates, and unless otherwise it was contraindicated, and all my patients were on orthotics of Crow Walker for a year. So results, all the patients were able to weight bear immediate post-operative period after a period of 3 weeks. Average was 5 to 8 months on ring, and they were all allowed to walk after 4 weeks. Wounds all healed. 80% had solid fusion, 20% had fibrous union, no other major complication. None of my patients have gone for amputation post-Elizarov ring fixator. There are a lot of studies, they have compared about internal fixation and external fixation. I find external fixators are better, ring fixators are better compared to internal fixation in a Charcot foot. So conclusion, Elizarov fixator may be an alternative method, effective means for neuropathic ankle arthrodesis, especially when the usage of internal fixation methods have some limitations. And disease like diabetes, percutaneous methods are better because of vascular compromise. Smokers are already warned on the recurrence of Charcot. Thank you. These are my references. Thank you.
Good evening. On behalf of Billroth Hospitals, we thank everyone for your kind presence and participation and making the CME program a grand success today. Thank you so much, all of you. We would like to thank our MD, Dr. Rajesh Jagannathan sir, and CEO, Dr. Kalpana madam, for continuously encouraging and supporting us to conduct these kind of CME programs. We thank Dr. Prem Kumar sir for chairing the session. Thank you so much, sir. We thank our distinguished speakers, Dr. Dhuriradhan sir, Balaji Saibaba sir, Bharani sir, and TV Raja sir. Thank you so much. It was a highly informative session. Thank you. We thank our organizing team for their timeless efforts towards the execution of the CME program. Let us seize this opportunity to not only expand our knowledge, but also forge new connections and friendships that will endure beyond these sessions. Thank you all the doctors and families for being here on this Sunday evening. Thank you so much. And please do join us for dinner. And let's meet up in the forthcoming CME programs of Billroth Hospitals in the future too. Thank you so much. Yes, please. We'll just pass the mic to you, sir. 1 minute.
Treatment modalities you have on both the disease. Okay. So Please don't
Based
mistake
on-
me. No, my humble request, because I was trained with Dr. Mohan Das. He was my teacher. Even when he was a teacher, I used to question him.
Okay. So in comparison, when you are looking at spinal infection due to TB and pyogenic organisms, X-rays look the same. There will be destruction of vertebral body, and disc space will be destroyed in both. MRI
Please
also.
speak a little loudly, sir. Come on.
I think. Am I audible now?
Yes,
Yeah.
sir.
Okay.
Please.
So X-ray wise, both look the same.
Thank you, sir.
Vertebral destruction, disc space reduction, both look the same. We have certain parameters that we look for in MRI that can distinguish a pyogenic infection from tuberculosis. Tuberculosis tends to produce more abscess.
Can I
more
ask one
vert-
question, sir?
Yeah, tell me, sir.
Do you differentiate pyogenic
From tuberculosis,
from
based on
tuberculosis?
some MRI
Are you
feature.
based on MRI or
Based on MRI, we can
blood test?
predict. We can predict. There are some signs which tell us that it could be a pyogenic infection. Where the abscess is more, it tends to be tuberculosis. When
Sir,
the disc space-
abscess of vertebral spine can be clinically diagnosed.
Sir,
There is no need
let
for
me
any.
try to understand why do you want to know this? Because
No,
finally,
because
the
my teachers
treatment.
taught me what.
So we cannot actually distinguish them. There are some parameters which
So do you
suggest
agree my teachers are better than my students?
No, sir, not really. No, I don't.
Okay, thank you, sir. Can I ask one question to the knee surgeon? Sorry, sir. I didn't want to discourage you.
Please, sir.
Thank you, sir, for your great presentation. My only question is, do you see the YouTubes?
YouTube?
Yeah.
Yeah.
I'm basically a good, what do you say?
YouTube.
I'm a good, I
YouTube.
can see a lot of patients. Say you can say I'm a GP. I've seen a lot of patients with osteoarthritis who have been trained with, who have been treated with Kenocort or Depometrazole, because maybe they are stage 1. And stage 2, we are going for hyaluronidase and with steroids. As you say, stage 3 they go for replacement. Am I right?
First, I give PRP, and then steroid, and then surgery.
All these failed. Now I have a patient undergone a TKR. Still patient has pain. What is the treatment you are going to give?
So I mentioned in the slide that the selection of patients should be very stringent, because there are patients, only patients who have.
Please don't mistake me. I am
Correct.
as
I've seen as well.
as a
Correct. I mean,
Yes,
as
close
I
my
said,
mic.
the selection process should be very stringent. We should select the correct patient, because the patient with severe osteoarthritic radiologically and impairment of function. And sometimes patient can have associated spine problems, which we may not evaluate when we do knee replacement. So that
that
also,
means there is a failure on part of the.
so
I agree. Okay.
basically evaluation of the spine
Okay,
is very important.
I had an opportunity to go into a YouTube where they say, what is this avocado? The seed of avocado mixed with alcohol. For at least 1 month. The range of movement and the pain reduction is better. See, I'm not discussing, I'm basically a allopathic surgeon. Okay? I always support allopathy. Are we missing somewhere? Do we somewhere going wrong? Or should we still have to go further? Sir, both of you. Sorry, please don't mistake me.
No, basically, you can try all the drugs which I was telling you, glucosamine, chondroitin sulfate, collagen, peptides, and whatever you said, soya beans, avocado, all those things are nutraceuticals, can be taken because they are harmless. But if the patient has got pain relief, and certainly they can continue with the treatment, and there is no reason why you should not try that first. And as I pointed out in the last slide, there are a lot of research going on in the development of new therapies. So those maybe will shed a light into the treatment of osteoarthritis.
Thank you, sir. I don't want to talk on this subject anymore. I just want to talk to the person who talked about Charcot joint. Sorry, sir. Please come, sir.
Yes, sir.
Please don't mistake me.
No, never
I am
mistake.
one of your
Yeah,
colleagues.
you can ask me anything on Charcot.
But my experience is maybe more than you. What is your age, sir?
My age is 56.
Sir, I am 66, sir.
Yeah, you can talk, sir. There's no problem.
But
Charcot is
I
a
have
open
been worked
topic.
in so many places.
Yes.
Maybe not big places
Yes,
like
yes,
you.
yes, yes.
But I have seen patients from lower category to the greatest category.
Yes, yes, yes.
My question is, you said Charcot's joint.
Yes.
These are the treatments. How many patients you have salvaged?
All
your-
my patients I've
One,
salvaged.
one second, sir.
With
You
surgery,
have
without
salvaged
surgery.
with your treatment.
Without surgery also we have salvaged.
Sir, my question is simple, sir.
Ask me, sir.
I have a lot of patients as well as my relatives
Yes.
who have been referred by a lot of
Question, sir.
orthopedicians.
Question.
My question is, how many patients you have salvaged with Charcot's joints, and what were their lifestyle after the
We have
treatment?
patients starting from laborers to politicians. Okay. Right from security officer to politicians we have treated. Okay. So all category, hard workers, everything. There are only two things in a Charcot. One thing, ulcer-free, pain-free food you have to give. That's it. Ultimately, plantigrade food is the option. You can manage it if there is no infection conservatively with a TCC and offloading footwear. Very basic. Anybody can manage it. If the ulcer goes and infects the joint and goes in for osteomyelitis, then only surgical option. You don't treat, put them on a plaster long time. That was a treatment that was given 20 years, 30 years back. That's what I said, TCC. That is what I showed you, total contact cost.
Okay,
Just
sir.
with the ulcer
A teacher.
Huh?
A teacher
Yes.
who comes to you with a Charcot's joint,
Huh?
how will you manage him? And
Anybody
what will be
anybody
the
who
end stage,
comes-
sir?
Huh?
What will be the end stage of the teacher?
End stage of the disease.
Maybe he is 50 years old.
I've
He
treated
he has to
40
retire
years.
at 50 years,
No, 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 no.
58 years, sir. Please
58,
don't
60,
mistake me.
65, everything we have treated up to 75. So, it is about giving them a plantigrade food. That is all with the pain-free food. That's
How
all
long,
we are
sir?
aiming at. Huh?
I am a teacher.
Anybody,
I want to teach in a medical
sir,
college.
My first case was done in 2007.
How long can I teach? How long can I stand?
Huh?
Can you
How
please
long?
support
No,
him,
no.
sir?
How long can you?
How long can I stand?
You can stand. It depends upon your activity. First is lifestyle modification. Lifestyle
Thank you, sir.
modification
Thank you,
is
sir.
very,
I
very
don't want to
important.
talk more than this. Thank you.
Thank you so much, sir. We'll just wind up the sessions. Thank you so much. We'll join us for dinner. Thank you. Thank you so much, sir. Thank you.